41, A15. 15-year-old boy with 15-year-old boy with hemophilia presents to his GP with progressive worsening. Worsening of right knee pain. Plain films exclude the presence of a fracture. All of the following are features of hemophilic arthropathy affecting the knee, except A. Epiphyseal enlargement. B. Widened intercondylar notch. C. Squared patella. D. Flattening of femoral condyles. E. Erlenmeyer-Flass deformity. 42. A7. 41. E. Erlenmeyer-Flass deformity. Erlenmeyer-Flass deformity is associated with thalassemia. Nonspecific findings of hemophilic arthropathy include joint effusion and periarticular osteopenia from hyperemia. Classical features include epiphyseal enlargement with associated gracile diaphysis. Differentials are juvenile rheumatoid arthritis. Secondary degenerative disease with symmetrical loss of joint cartilage involving all compartments equally with periarticular erosions, subchondral cysts, osteophytes, and sclerosis is seen in end-stage arthropathy. Specific findings at the knee include widened intercondylar notch, squared margins of the patella, expanded femoral condyles, and flattened surface of femoral condyles. Specific findings at the elbow include enlargement of the radial head and widening of the trochlear notch. Dannert W. Radiology Review Manual. Philadelphia, PA, Lippincott, Williams & Wilkins, 2007. Weiss letter R. ETAL Primer of Diagnostic Imaging. 42. A 7-year-old boy presents with acute scrotum. Which one of the following features on ultrasound is more suggestive of a diagnosis other than testicular torsion? A. Abnormal testicular texture. B. Testicular swelling. C. Coiled spermatic cord. D. Scrotal wall edema. E. Decreased or absent blood flow. Imaging. Maryland Heights, M.O., Mosby Incorporated, 2003. 42. D. Scrotal wall edema. Differential diagnosis of acute scrotum includes testicular torsion, the most important differential, along with torsion of the testicular appendix, epididymitis and epididymoorchitis. U.S., including the use of Doppler imaging, plays a vital role in distinguishing between these diagnoses. All of the above features can be seen in testicular torsion, along with such findings as epididymal enlargement and hydrocele. However, scrotal wall edema is the only one of these findings that is more commonly seen with alternative causes of acute scrotum than it is with acute testicular torsion. Decreased or absent blood flow is considered the most important finding, although torsion is not excluded if there is normal or increased blood flow, which may occur after spontaneous detorsion. Dannert W. Radiology Review Manual. 43. All of the following are true of herpes simplex encephalitis, except A. It mostly affects the limbic system. B. CT may be negative in the first few days. C. There is a tendency for hemorrhage. D. Increased signal is seen on T2W images in the temporal lobe. E. DWI shows low signal in the affected area. 6th ed. Philadelphia, PA, Lippincott, Williams & Wilkins, 2007:975. Karmazin B. ETAL Clinical and Sonographic Criteria of Acute Scrotum in Children, a retrospective study of 172 boys. Pediatra Radiol. 2005, 35:30210. 43. E. DWI shows low signal in the affected area. In the immunocompetent adult patient, the pattern is quite typical and manifests as a bilateral asymmetrical involvement of the limbic system, medial temporal lobes, insular cortices, and infralateral frontal lobes. The basal ganglia are typically spared. Extralimbic involvement is more prevalent in children than in adults, seen most commonly in the parietal lobe, with sparing of the basal ganglia. Eventually, it results in marked cystic encephalomalacia and volume loss in affected areas. In immunocompromised patients, involvement can be more diffuse and is more likely to involve the brainstem. Early diagnosis is difficult and a normal CT is often seen. Affected areas appear low on T1, weighted MRI due to edema. High T1 signal suggests areas of hemorrhage. Post-contrast enhancement is usually late and can be gyral, leptomeningeal, ring or diffuse enhancement. Affected white matter and cortex appears high signal on T2, weighted and flare images. Areas of hemorrhage show low T2 signal and blooming artifact. DWI is more sensitive than T2, weighted images. Cytotoxic edema is seen as high signal on DWI with corresponding low signal on ADC map. Vasogenic edema is bright on both, T2 shine through. Bulak base IN, Cocoa glue M. 44, CXR demonstrates a mediastinal mass. The heart borders are not obscured and the hilar vessels are visible. Which of the following is in keeping with the CXR findings? A. Lymphoma. B. Teratoma. C. Retrosternal goiter. D. Nerve sheath tumor. E. Left ventricular aneurysm. Chapter 5. Images. Cytotoxic edema is seen as high signal on DWI with corresponding low signal on ADC map. Vasogenic edema is bright on both, T2 shine through. Bulak base IN, Cocoa glue M. Central nervous system infections of herpes virus family. Neuroimaging Clin NAM. 2008, 18, 153-84. 44. D. Nerve sheath tumor. Anatomical and radiological division of the mediastinum into anterior, middle and posterior varies. Anatomically, structures in the pericardial space including great vessels constitute the. Chapter 6. Test paper 3, answers. 153. Middle mediastinum, structures anterior to the pericardial sac constitute the anterior mediastinum, and structures behind the sac constitute the posterior mediastinum. The Felsen method of radiological division is based on lateral chest radiography. A line extending from the diaphragm to the thoracic inlet along the back of the heart and anterior to the trachea separates the anterior and middle mediastinum, whereas a line that connects points 1 cm behind the anterior margins of the vertebral body separates the middle and posterior mediastinal compartments. The hilum overlay sign is present when the normal hilar structures project through a mass, meaning that the mass is either anterior or posterior to the hilum. Loss of anterior junction line and cardiac contours would suggest anterior location. Preservation of these lines and the loss or widening of the posterior junction lines, paraspinal lines, would suggest posterior location. Lymphoma, teratoma, and goiter are anterior mediastinal masses. Nerve sheath tumors are the only true posterior mediastinal structures amongst the examples. Witten Cr. ETAL. Diagnostic approach to mediastinal abnormalities. Radiographics. 2007, 27, 3657-71. 45, C. It is usually associated with change in bowel habits. The condition most commonly manifests in the 4th to 5th decades of life, predominantly in 45, a 27-year-old woman is complaining of lower abdominal pain localized to the left iliac fossa. A CT scan raises a suspicion of epiploic appendicitis. All of the following statements about epiploic appendicitis are true, except A. Treatment is usually medical. B. It can mimic acute appendicitis or diverticulitis. C. It is usually associated with change in bowel habits. D. Most patients have normal inflammatory markers. E. The most common site of appendicitis is adjacent to the sigmoid colon. In men. With diagnosis based on clinical manifestations alone, acute epiploic appendicitis is misdiagnosed in the majority of patients. Clinically, acute epiploic appendicitis manifests with acute onset of pain, most often in the left lower quadrant, and this symptom often leads to its being mistaken for acute diverticulitis. Unlike acute epiploic appendicitis, acute diverticulitis is more likely to manifest with evenly distributed lower abdominal pain, and to be associated with nausea, fever and leukocytosis. Although most patients with acute epiploic appendicitis do not report any change in their bowel habits, a minority experience constipation or diarrhea. Most patients with acute epiploic appendicitis have a normal white blood cell count and body temperature. CT images from less than 8% of patients evaluated for exclusion of sigmoid diverticulitis or appendicitis show features of primary acute epiploic appendicitis. When acute epiploic appendicitis involves the cecum or ascending colon, it may be mistaken clinically for acute appendicitis. The most common sites of acute epiploic appendicitis, in order of decreasing frequency, are areas adjacent to the sigmoid colon, the descending colon, and the right hemicolon. Sing AK, ETAL acute epiploic appendicitis and its mimics. Radiographics. 2005. 46, a 35-year-old man undergoing a plain abdominal X-ray in the A&E department reveals multiple punctuate areas of calcification over both renal areas. Review of the notes reveals a history of upper GI endoscopy and previous psychiatric consultations. Which of the following are you going to suggest in your report? A. Urology referral and check of serum TSH levels. B. Urology referral and check of serum parathyroid hormone levels. C. Urology referral and check of serum alkaline phosphatase. D. Urology referral and check of serum LDH. E. Urology referral and check of serum calcitonin levels. 47, a previously well 29. (2005, 25:15-21:34). 46, B. Urology referral and check of serum parathyroid hormone levels. The most common clinical manifestations of hyperparathyroidism include renal stones and nephrocalcinosis, high blood pressure, acute arthropathy, CPPD, osteoporosis, peptic ulcer, acute pancreatitis, proximal muscle weakness, depression and confusional state, often described in medical textbooks as stones, groans and moans. It is diagnosed by raised serum parat hormone levels. Serum TSH levels are related to hyper and hypothyroidism. Calcitonin is typically raised in medullary carcinoma of the thyroid. Serum alkaline phosphatase is a non-specific enzyme marker, which is raised in several inflammatory, metabolic and malignant conditions. LDH is also a non-specific enzyme marker, raised in heart disease and myositis. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a text 29-year-old presents with inversion injury. An X-ray demonstrates no fracture. However, there is a well-circumscribed lesion in the tibia with a ground glass matrix and a narrow zone of transition. There is no periosteal reaction or associated soft tissue mass. Which of the following is the most likely diagnosis? A. Polyostotic fibrous dysplasia. B. Osteosarcoma. C. Osteoid osteoma. D. Adamantinoma. E. Monostotic fibrous dysplasia. 48. A 2-year-old boy presents with bowing of the left leg. Specific enzyme marker, which is raised in several inflammatory, metabolic and malignant conditions. LDH is also a non-specific enzyme marker, raised in heart disease and myositis. Adam A. et al. Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:1099-1100. 47. E. Monostotic fibrous dysplasia. Fibrous dysplasia is an uncommon, benign disorder characterized by a tumor-like proliferation of fibroosseous tissue. It may either present as monostotic, affecting one bone, or polyostotic, affecting many bones. Fibrous dysplasia is usually found in the proximal femur. Chapter 6. Test paper 3, answers. 154. Tibia, humerus, ribs and craniofacial bones in decreasing order of incidence. Polyostotic cases can affect multiple adjacent bones or multiple extremities. Men and women are equally affected by the disorder. Fibrous dysplasia is usually asymptomatic, although pain and swelling may accompany the lesion. Radiographically, fibrous dysplasia appears as a well-circumscribed lesion in a long bone with a ground glass or hazy appearance of the matrix. There is a narrow zone of transition and no periosteal reaction or soft tissue mass. The lesions are normally located in the metaphysis or diaphysis. There is sometimes focal thinning of the overlying cortex, called scalloping from within. The radiological appearance can also be cystic, pagetoid, or dense and sclerotic. Repeated fractures through lesions in the proximal femur can result in the formation of a so-called shepherd's crook deformity. The TC99M bone scan uptake may be normal or increased. Bone scans are not helpful in diagnosing these lesions, but can be useful in identifying asymptomatic lesions. MRI or CT scans can be helpful in delineating the extent of the lesion and identifying possible pathological fractures. Leg. There is no history of trauma, and the right leg appears normal. Standing anteroposterior radiography is performed. This shows a varus deformity of the left knee with fragmentation of the posteromedial tibial metaphysis and absence of the medial epiphysis. The right leg appears radiographically normal and bony density is preserved throughout. Which of the following is the most likely cause? A. Neurofibromatosis. B. Blount disease. C. Congenital bowing. D. Developmental bowing. E. Osteogenesis imperfecta. 49. Barium swallow shows anterior indentation of the esophagus and posterior indentation of the trachea. The cause for this is A. Aberrant right subclavian artery. B. Double aortic arch. C. Right-sided aortic arch. D. Aberrant left pulmonary artery. E. Aberrant left subclavian artery. 50. A 34-year-old woman has been complaining of acute right upper quadrant pain for the last 2 days. Her inflammatory markers are raised and she looks unwell. She is known to have gallstones from a previous U.S. study. All of the following are Mr. findings consistent with the diagnosis of acute cholecystitis, except A. Gallbladder wall thickening greater than 3 mm. B. Gallbladder wall edema. Chapter 5. Test paper 3, questions. 127. C. Contracted gallbladder. D. Pericholecystic fluid. E. Echogenic bile. Fracture. However, there is a well-circumscribed lesion in the tibia with a ground glass matrix and a narrow zone of transition. There is no periosteal reaction or associated soft tissue mass. Which of the following is the most likely diagnosis? A. Polyostotic fibrous dysplasia. B. Osteosarcoma. C. Osteoid osteoma. D. Adamantinoma. E. Monostotic fibrous dysplasia. 48. A 2-year-old boy presents with bowing of the left leg. There is no history of trauma, and the right leg appears normal. Standing anteroposterior radiography is performed. This shows a varus deformity of the left knee with fragmentation of the posteromedial tibial metaphysis and absence of the medial epiphysis. The right leg appears radiographically normal and bony density is preserved throughout. Which of the following is the most likely cause? A. Neurofibromatosis. B. Blount disease. C. Congenital bowing. D. Developmental bowing. E. Osteogenesis imperfecta. Scans are not helpful in diagnosing these lesions, but can be useful in identifying asymptomatic lesions. MRI or CT scans can be helpful in delineating the extent of the lesion and identifying possible pathological fractures. Sarcoma 2 change within the lesion can be identified by MRI or CT. Kronsdorff ML, ETAL fibrous dysplasia. Radiographics. 1990, 10/3/5/1937. 48b. Blount disease. All of the answers can lead to leg bowing in pediatric groups. However, the description is that of Blount disease, otherwise known as tibia vara. This is a common condition that is unilateral or asymmetrical, and is thought to arise as a result of abnormal stress, such as obesity and walking at an early age, on the posteromedial proximal tibial physis. There are 3 types: infantile, the most common, juvenile, and adolescent. Anteroposterior radiography of both legs is necessary. Neurofibromatosis may cause anterolateral tibial bowing, possibly with fibular hypoplasia, and one or both bones may fracture to give a pseudarthrosis. Developmental or physiological bowing is where there is exaggeration of varus angulation between the ages of 12 and 24 months, which again may be caused by obesity or early walking. There is metaphyseal beaking but no fragmentation. And it is usually symmetrical and bilateral. Congenital bowing is usually convex posteromedially. Unlike neurofibromatosis, marked dorsiflexion of the foot is evident at birth, as this condition is thought to arise from an abnormal intrauterine position. Radiography shows thickening of the cortex of the concavity of the curvature. Osteogenesis imperfecta causes bowing of multiple long bones as a result of osteoporotic softening and fractures, hence bone density reduction and bilateral bowing would be more likely. Chima G, ETAL radiographic character. Imperfecta. 49. Barium swallow shows anterior indentation of the esophagus and posterior indentation of the trachea. The cause for this is A. Aberrant right subclavian artery. B. Double aortic arch. C. Right-sided aortic arch. D. Aberrant left pulmonary artery. E. Aberrant left subclavian artery. 50. A 34-year-old woman has been complaining of acute right upper quadrant pain for the last 2 days. Her inflammatory markers are raised and she looks unwell. She is known to have gallstones from a previous U.S. study. Characteristics of lower extremity bowing in children. Radiographics. 2003, 23:87180. 49. D. Aberrant left pulmonary artery. Vascular anomalies of the aortic arch and the pulmonary artery can cause vascular impression on the barium-filled esophagus. The most common is a right-sided aortic arch, which results in an indentation on the right and absence of normal aortic impression on the left. Bilateral indentation is caused by a double aortic arch. The right arch is normally higher and larger than the left. Aberrant right subclavian artery from a normal arch, or an aberrant left subclavian artery from a right-sided arch traverses behind the esophagus as it crosses the mediastinum, and results in a posterior impression on the esophagus seen on a lateral view. An aberrant left pulmonary artery traverses between the trachea and esophagus above the carina, resulting in a posterior indentation on the trachea, and an anterior indentation on the esophagus on lateral view. Coarctation of the aorta results in a reverse 3 impression on the left of the esophagus on an AP image. Type 3 anomalous pulmonary veins traverse the diaphragm with the esophagus and. Chapter 6. Test paper 3, answers. 155. Drain into a systemic vein, causing an impression on the anterior wall of the esophagus, low down close to the diaphragm. Eisenberg R.L. Extrinsic impressions on the thoracic esophagus. In Gastrointestinal Radiology, a Pattern Approach, 4th ed. Eisenberg R.L., ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2003, 2742. 50. C. Contracted gallbladder. Study. All of the following are Mr. findings consistent with the diagnosis of acute cholecystitis, except A. Gallbladder wall thickening greater than 3 mm. B. Gallbladder wall edema. Chapter 5. Test paper 3, questions. 127. C. Contracted gallbladder. D. Pericholecystic fluid. E. Echogenic bile. 51. A 65-year-old man with 3 months history of painless hematuria was diagnosed as having a primary bladder cancer on cystoscopy. An MRI of the pelvis is scheduled for staging. With regard to MRI for staging of bladder cancer, which of the following is incorrect? A. Papillary tumor is best seen on T1W images. B. Infiltrating component is better assessed with post-contrast T1W than T1W than T2W images. Gallbladder features of acute cholecystitis include thickened GB wall for 5 mm, echogenic bile/sludge, gallbladder distension, cholecystic fluid in the absence of ascites and subserosal edema. Contracted GB is generally a feature of chronic cholecystitis. Dannert W, radiology images. C. Endorectal coil improves visualization of bladder wall layers. D. T2W helps in differentiating T2B and T3 tumors. E. Involved seminal vesicles show high signal on T2W images. 52. The following are true regarding hyperparathyroidism, except A. Brown tumors are more common in the primary form. B. Soft tissue calcification is typically associated with the secondary form. C. Chondrocalcinosis is more common in the primary form. D. Osteosclerosis is more common in the primary form. E. Bone resorption is equally seen in both primary and secondary conditions. Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:713-4. 51. E. Involved seminal vesicles show a high signal on T2W images. Mr. Tumor staging criteria follow the TNM system. A papillary tumor is best seen on T1 weighted images, where it is seen as higher signal than the urine. It appears similar in signal intensity on T2 weighted sequences. Tumor demonstration, especially a small one, is facilitated by use of contrast. To evaluate infiltration, T2 weighted or post-contrast T1 weighted sequences are required. Use of surface coils, endorectal coils, improves visualization of layers of the bladder wall, improving staging of T2-T3b tumors. Visualization of low-intensity bladder wall on T2 weighted sequence between the tumor and perivesical fat helps in differentiating a T2b tumor from a T3 tumor. Disruption of low-signal bladder wall, perivesical fat stranding, and irregularity of the outer bladder wall suggests T3b disease. Dynamic contrast-induced MRI improves bladder cancer staging accuracy by helping differentiation of tumor, enhances earlier, from inflammatory post-biopsy changes in the bladder wall or perivesical fat, slower rate of enhancement. It is also useful in staging nodes, because abnormal nodes, normal or abnormal by size, enhance earlier than non-metastatic lymph nodes. Involvement of the seminal vesicle is evident as an increase in size of the vesicle, reduced T2 signal, and obliteration of the angle between the seminal vesicle and posterior bladder wall. In contrast, invasion of the prostate and rectum is seen as direct tumor extension, and an increase in signal intensity on T2 weighted images. T staging of bladder tumors. TA, non-invasive papillary tumor TIS, in situ, non-invasive flat, T1, through lamina propria into subepithelial connective tissues T2A, only invades the inner half of the muscle T2B, invades into the outer half of the muscle T3A, microscopic extravesical invasion T3B, macroscopic extravesical invasion T4, direct invasion into adjacent structures, prostate, uterus, vaginal vault T4B, direct involvement of pelvic side wall and / or abdominal wall. Adam A. E. T. A. L. Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:892-3. 52. D. Osteosclerosis is more common in the primary form. Osteosclerosis, as seen in the Ruger Jersey spine, is associated with the secondary form of hyperparathyroidism from chronic renal failure. The rest of the statements are true. In summary, the radiological findings, which are more associated with the primary form, include brown tumors, subperiosteal bone resorption, soft tissue calcification, although less common than in the secondary forms, and chondrocalcinosis. The findings for secondary hyperparathyroidism include subperiosteal bone resorption, osteosclerosis, and soft tissue calcification. Dannert W, Radiology Review Manual, 6th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2007:105. Chapter 6. Test Paper 3, Answers. 156. 53. D. 53. All of the following are associated with multiple focal hyperintensities in both cerebral hemispheres, except A. Cadasal B, ADEMC, MSD, epidermoid E. Sarcoidosis. 54. A 12-year-old girl with known thalassy Epidermoid causes of white matter hyperintensities are protean, however certain categories are recognized. These include the following: hypoxic/ischemic etiology secondary to hereditary conditions, Fabry's disease, PKU, MELAS, amyloid deposition, Cadacil, Moya-Moya, Rondeau-Weber-Osler syndrome, etc., or acquired conditions, hypertension, atherosclerosis, NPH, embolic events, Wallerian degeneration, etc. Inflammatory conditions like MS and its variants, ADEM, SSPE, vasculitis, Bessett's disease, GCA, PAN, etc., sarcoid, bacterial, protozoal, viral, HSV, HIV, PML, spirochetal, Lyme disease, and fugal. Toxic or metabolic causes like CPM, co-intoxication, methotrexate treatment, Marchief-Bignami syndrome, and B12 deficiency. Other conditions include radiation, contusion, histiocytosis, and Erdheim-Chester disease. Epidermoid cysts are extraparenchymal, mimic CSF, do not enhance, and show restricted diffusion. Barkhoff F. Skelton's P. Imaging of white matter lesions. Cerebrovasc DIS 2002, 13 Supple 2, 2130. 54. C. Occipital bone thalassemia major. Thalassemia major undergoes skull radiography. Which area of the skull is least affected by this condition? A. Facial bones. B. Frontal bone. C. Occipital bone. D. Temporal bone. E. Parietal bone. 55. As with other causes of chronic anemia, causes widening of the diploic space in the skull as a result of marrow hyperplasia, with thinning of the outer table and thickening of the inner table. A hair-on-end appearance is seen, with periosteal bony spicules extending beyond the outer table. The occipital bone normally has a lower bone marrow content, and is therefore not affected to the same extent by these changes. Occasionally, solitary or multiple lytic lesions may be seen in the skull. Paranasal sinuses and mastoids are often absent or undernumitist owing to frontal, temporal and facial bone marrow hyperplasia. The ethmoid sinuses are the exception because there is minimal marrow content in the surrounding bones. Tyler Pa, et.al. The radiological appearances of thalassemia. Clinical Radiol. 2. 55. A 30-year-old man recently treated with bone marrow transplant for acute myeloid leukemia 12 weeks ago presents with cough and fever. HRCT demonstrates multiple micronodules with areas of consolidation and ground glass attenuation. What is the likeliest diagnosis? A. Pneumocystis carinii pneumonia. B. Cytomegalovirus pneumonitis. C. Drug toxicity. D. Acute rejection. E. Graft versus host disease. 2006, 61:4052. 55. B. Cytomegalovirus pneumonitis. Early complications include interstitial pneumonitis, infective and non-infective types, infection, edema, hemorrhage, thromboembolism, and calcification. COP is a rare complication that may occur early or late. Cytomegalovirus, CMV, is the most important viral pathogen that causes pneumonia in transplant recipients. RSV, HHV6, Pneumocystis jirovecii, and adenovirus are less common. Idiopathic interstitial pneumonia has various causes including acute graft versus host disease. Unfortunately, CT appearances of both infectious and non-infectious interstitial pneumonitis are nonspecific. Notable features include increased interstitial markings, multilobar infiltrates, areas of ground glass opacity, and nodules. Biopsy is frequently undertaken to identify the cause. Levine DS, et.al. Imaging the complications of bone marrow transplantation. Disease. Transplantation in children. Radiogram 2007, 27, 230724. Disease. 56, a 49-year-old man patient previously fit and well has been admitted with acute epigastric pain and raised amylase. A diagnosis of pancreatitis is made. What is the most appropriate imaging examination for assessment of acute pancreatitis? A. Abdominal radiography. B. Ultrasound. C. Magnetic resonance cholangiopancreatography, MRCP. D. Contrast-enhanced CT. E. EUS. 24. 56. D. Contrast-enhanced CT. Contrast-enhanced CT is the imaging modality of choice for the diagnosis and staging of acute pancreatitis. The pancreas enhances uniformly in mild acute pancreatitis and may be normal or enlarged with a variable amount of increased attenuation in the adjacent fat, termed stranding. Local edema is a common finding and may extend along the mesentery, mesocolon, and hepatoduodenal ligament and into the peritoneal spaces. Extension of edema to fluid into the anterior perirenal space may create a mass effect and a halo sign with sparing of the perinephric fat. Chapter 6. Test paper 3, answers. 157. Abnormal ultrasound findings are seen in 33%-90% of patients with acute pancreatitis. Interstitial edema in acute pancreatitis is depicted on ultrasound as an enlarged hypoechoic gland. Although ultrasound may be used to identify peripancreatic acute fluid collections, it is not useful for the detection of necrosis. Thus its main role in the imaging of acute pancreatitis is limited to the detection of cholelithiasis and cholecystolithiasis and identification of fluid collections in the peritoneum, retroperitoneum, and pleural spaces. O'Connor O.J., ETAL imaging of acute 57. Regarding prostatic MRI, which of the following is true? A. Zonal anatomy is best seen on T1. B. The central and transition zones show similar low signal. C. The transition zone is heterogeneous in the young. D. The peripheral zone maintains a uniform shape throughout the length of the gland. E. US is better than MRI for assessing prostate volume. Pancreatitis. AJR AMJ Röntgenal. 2011, 197, W221-5. 57, B. The central and transition zones show similar low signal. On T1 weighted images, the prostate shows homogeneous intermediate signal intensity, and the zones cannot be differentiated. The zonal anatomy is best seen on T2 weighted images with the peripheral zone showing a high signal compared to both the central and the transitional zones. The central and transitional zones have similar low signal. At a young age, the transitional zone is homogeneous low signal. It gets increasingly heterogeneous with age and BPH changes. On T2 weighted images, the shape of the peripheral zone changes from the base to apex. At the base, the peripheral zone surrounds the posterolateral aspect of the central zone, while at the apex it concentrically surrounds the central zone. The prostatic capsule separates the peripheral zone from the periprostatic tissue, whereas the surgical pseudocapsule separates the peripheral zone from the transitional zone in the older population. MRI is recognized to be more accurate than US and CT. In assessment of prostate volume. Adam A., ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. 58, a 25-year-old woman presents to the A&E department with an acutely painful right hip and difficulty in weight-bearing. A radiograph is obtained in casualty. No fractures are identified, but the radiograph reveals a subluxed femoral head on the right with a shallow acetabulum and a center edge angle of 18 degrees. What is your diagnosis? A. Pertussis Disease. B. Allius Disease. C. Developmental Dysplasia of the hip. D. Traumatic subluxation. E. Congenital coxavara with subluxation. 59, a 50. Ed. New York, Churchill Livingstone, 2008:899-900. 58, C. Developmental dysplasia of the hip. The patient has developmental dysplasia of the hip, which has resulted in subluxation of the femoral head. The center edge angle is useful in older toddlers up to adulthood to estimate the degree of acetabular over or under coverage. It is the angle between a vertical line drawn up from the center of the femoral head and the outer edge of the acetabular roof. In an adult, an angle less than 20 degrees indicates underlying dysplasia. Pertussis disease is a pediatric condition characterized by avascular necrosis of the femoral head. Allius disease is the condition of multiple enchondromas, enchondromatosis. Isolated traumatic subluxation requires significant trauma in the absence of an underlying dysplasia. Danner W. Radiology Review Manual, 6th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2007:65-6. 53-year-old woman with facial pain shows a lobulated, homogeneous CSF density mass in the left CP angle on CT. No contrast enhancement is evident and the differentials considered are either an arachnoid cyst or an epidermoid cyst. Which of the following investigations will you consider to confirm your diagnosis? A. Mr. Angiogram of the circle of Willis. B. Diffusion-weighted MRI. C. PET CTD, post-gadolinium. Mr. Brain. E. Mr. Spectroscopy. 60, a 15-year-old girl presents with acute pelvic pain. 6. 59, B. Diffusion-weighted MR imaging. Epidermoid cysts are characteristically well demarcated and have a homogeneous low density, similar to CSF on CT scan, showing no contrast enhancement. On MRI, epidermoid cysts are hypointense on T1 weighted images and hyperintense on T2 weighted images. On FLAIR, epidermoid cysts become hyperintense or appear more heterogeneous compared to an arachnoid cyst. There are occasions when an epidermoid may appear as a low-intensity lesion on FLAIR. However, on diffusion-weighted imaging, epidermoid cysts show restriction and remain bright due to a combination of true restricted diffusion and T2 shine-through. The latter helps with definitive differentiation of an epidermoid cyst from an arachnoid cyst. Did SN, ETAL radiologic differentiation of intracranial epidermoids from arachnoid cysts. Pain. Beta human chorionic gonadotrophin, beta HCG, is normal. US demonstrates a thin-walled 5 cm echogenic adnexal mass with posterior acoustic enhancement. There is no color internal Doppler signal. Follow-up imaging after 3 months fails to demonstrate the mass. What is the most likely cause? A. Appendix abscess. B. Hemorrhagic ovarian cyst. C. Ovarian dermoid. D. Ectopic pregnancy. E. Ovarian torsion. Cysts. Otol neurotol. 2002, 23, 184-92. 60. B. Hemorrhagic ovarian cyst. All of the above may present as a right hemipelvic mass. Hemorrhage into an ovarian follicular cyst is the most common of these, and it usually resolves after 1 or 2 menstrual cycles. Several patterns of ultrasound findings have been described, including an echogenic mass, a ground glass pattern, diffuse low-level echoes, a world pattern of mixed echogenicity. Chapter 6. Test paper 3, answers. 158. An fishnet weave pattern, fine septations or reticular echoes. Appendix abscess would be thick-walled. Ovarian dermoid may present as an echogenic mass, although acoustic shadowing would be more typical owing to internal calcifications, and would not resolve in this fashion. Ectopic pregnancy may present as an echogenic tubal mass, although elevated beta-HCG would be a feature. Ovarian torsion may appear as an enlarged echogenic ovary, owing to edema, and, like hemorrhagic cyst, often lacks internal color Doppler flow, although it is less common than hemorrhagic cyst. It would also necessitate urgent surgery rather than follow-up imaging. Dannert W., Radiology Review Manual, 6th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2007:1054-6. Donnelly L.F. Torsion. 61. A truck driver has been involved in an RTA. He has sustained head injuries and lower limb fractures. A CT performed 3 hours after injury shows small patches of consolidation within the posterior aspect of the lungs. What are these most likely to represent? A. Fat embolism. B. Pulmonary contusion. C. ARDS. D. Traumatic lung cysts. E. Pulmonary embolism. 62. A20. LF. Pediatric imaging, the fundamentals. Philadelphia, PA, Saunders Elsevier, 2009:151-3. 61. B. Pulmonary contusion. Lung contusion is the most common type of lung injury in blunt chest trauma. It occurs at the time of injury, but it may be undetectable on chest radiography for the first 6 hours after trauma. However, CT may show it immediately. The pooling of hemorrhage and edema will blossom at 24 hours, rendering the contusion more evident. The appearance of consolidation on CXR, after the first 24 hours, should raise the suspicion of other pathological conditions such as aspiration, pneumonia, and fat embolism. Clearance of an uncomplicated contusion begins at 24-48 hours with complete resolution after 3-14 days. Lack of resolution within the expected time frame should raise the suspicion of complications such as pneumonia, abscess, or ARDS. Lung laceration results in ground glass change or consolidation with pneumatocoel, hematocele, or pneumothorax. Rib fractures may be associated with peripheral lacerations. Oikonomu A. Prasopoulos P. CT imaging of blunt chest trauma. 27-year-old woman who is 26 weeks pregnant has been complaining of lower abdominal pain, which has gradually settled in the right iliac fossa. On surgical review, she is suspected to have acute appendicitis. An MRI of the abdomen is organized. All of the following features are expected features of acute appendicitis on MRI, except A. Caliber of greater than 7 mm. B. Thick wall greater than 2 mm. C. High signal intensity luminal contents. Chapter 5. Trauma. Insights Imaging. 2011, 2-3-281-95. 62. Low luminal signal intensity on T1 and T2. Weighted images. MR imaging features of a normal appendix include a diameter less than 6 mm, an appendiceal wall thickness less than 2 mm, low luminal signal intensity on T1 and T2. Weighted images and no periappendiceal fat stranding or fluid. MRI features of appendicitis include an appendiceal diameter greater than 7 mm, an appendiceal wall thickness greater than 2 mm, high signal intensity luminal contents on T2, weighted images due to fluid or edema, and hyperintense periappendiceal fat stranding and fluid. An appendix with high signal intensity luminal contents on T2, weighted images, and a diameter between 6 and 7 mm without associated wall thickening organ periappendiceal fat stranding or fluid is considered indeterminate for appendicitis and warrants close clinical follow-up. MRI has been described as an effective modality for the diagnosis of appendicitis during pregnancy, with 100% sensitivity and 94% specificity reported. Spolito LB, MR imaging of Test paper 3, questions. 129. D. Periappendiceal fat stranding. E. Low luminal signal intensity on T1 and T2 weighted images. 63. A 75-year-old man undergoing MRI of the prostate for known malignancy reveals low signal intensity in the peripheral zone of the prostate on T2W images extending from the 3 o'clock position to the 8 o'clock position. Further note is also made of bulky low signal seminal vesicles bilaterally. What is the T stage of the tumor? Imaging evaluation of abdominal pain during pregnancy, appendicitis, and other non-obstetric causes. Radiographics. 2012, 32:317-34. 63. D. T3B T staging of prostate cancer. T1, not palpable via DRE or seen using truss. T1A, cancer found incidentally during TURP, less than 5% of the gland. T1B, cancer found incidentally but over 5% of the gland is involved. T1C, found by needle biopsy for a raised PSA. T2, palpable on DRE but confined to the prostate. T2A, less than half of one lobe. T2B, more than half of one lobe. T2C, cancer in both lobes of the prostate. Chapter 6. Test paper 3, answers. 159. T3, spread outside the prostate. T3A, extracapsular extension, one or both sides. T3B, tumor invades the seminal vesicles. T4, spread into the adjacent tissues, other than seminal vesicles. Clause FG, ET. Vesicles bilaterally. What is the T stage of the tumor? A. T2BB, T2CC, T3AD, T3BE, T4. 64, a 52-year-old woman is involved in a RTA. Trauma series radiographs reveal a complex pelvic fracture. There are no other appreciable injuries. She is hemodynamically unstable, and fluid resuscitation is commenced. Which of the following steps is the next most important? A. Trauma protocol CT scan with angiographic sequences. B. Immediate surgery under the orthopedic surgeons. C. Discussion with interventional radiologists with view to catheter angiography and possible intervention. D. Placement of a pelvic wrap device. E. Blood transfusion. 65. CT brain of a 10-year-old girl shows a large ETAL pretreatment evaluation of prostate cancer. Cancer, role of MR imaging and 1H Mr spectroscopy. Radiographics. 2004, 20 for supple 1, S16780. 64D. Placement of a pelvic wrap device. All of these steps may be required, but the most important is to place a pelvic wrap device. The purpose of this device is to stabilize the pelvis. If the patient is hypotensive as a result of venous bleeding, a pelvic wrap should stabilize the pelvis sufficiently to cause significant reduction or cessation in the venous hemorrhage, and thus avoid unnecessary endovascular intervention. If this fails to achieve sufficiently prompt hemodynamic stability, there is a significant chance that there is arterial hemorrhage, hence endovascular intervention is likely to be necessary. Many centers use angiographic sequences as part of the trauma CT scan to identify such a bleeding point as part of planning stage of endovascular management. CT would be the next step once the pelvic binder is in situ. Zeoli IA, Chakravarti S. The role of interventional radiology in trauma. Cyst in the posterior fossa. All of the following favor pielocystic astrocytoma over hemangioblastoma, except A. Size greater than 5 cm. B. Calcification. C. Smaller nodule. D. Thicker-walled lesion. E. No angiographic contrast blush of the mural nodule. Trauma. Brit Med J. 2010, 340:35660. 65. C. Smaller nodule pilocytic astrocytoma is the most common pediatric cerebellar neoplasm and the most common pediatric glioma. They can be differentiated from hemangioblastoma on the following basis. Astrocytomas are more likely to be larger than 5 cm, contain calcification, have a larger mural nodule, are thick-walled lesions, do not show angiographic contrast blush to the mural nodule, and are not associated with erythrocythemia. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:273-4. Nodule. 66. An 8-year-old girl is admitted with sudden onset acute pelvic pain, and ovarian torsion is suspected. Which of the following statements regarding ovarian torsion is least accurate? A. Benign cystic teratoma is the most common neoplastic cause. B. It most commonly occurs on the left. C. The whirlpool sign is a feature on ultrasound. D. The most common finding is asymmetric ovarian volumes. E. An urgent referral to gynecology should be made. 66. B. It most commonly occurs on the left. Ovarian torsion is most common in prepubertal girls and may be caused by ovarian enlargement, for example owing to neoplastic causes, of which benign cystic teratoma is the most common, or abnormally increased adnexal mobility. It is more common on the right than the left, which is postulated to occur because of a protective effect of the sigmoid colon on the left side. On ultrasound, the most reliable positive finding is asymmetry between the volumes of the right and left ovaries. Arterial Doppler waveform is usually but not always absent, as there is blood supply from both the ovarian and uterine arteries. A whirlpool sign may be seen because of twisting of the ovarian pedicle. Treatment is with emergency surgery, hence immediate referral to gynecology is required. Dannert W. Radiology Review Manual, 6th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2007:1064-5. Donnelly L.F. Pediatric Imaging, The Fundamentals. Philadelphia, PA. Made. 67, a 20-year-old man with a history of thrombophlebitis and recurrent mouth and genital ulcers undergoes a CXR. A well-defined opacity in the right hilum is noted. Contrast-enhanced CT confirms that the opacity has sharp borders, with intense enhancement in the arterial phase. What is the most likely diagnosis? A. Pulmonary artery aneurysm. B. Pulmonary vein varix. C. Necrotic hilar node. D. Endobronchial carcinoid. E. Pulmonary AVM. Pa. Saunders Elsevier, 2009:1064-5. 67. A. Pulmonary artery aneurysm. One of the most common findings of Behçet's disease, at chest radiography, is a lung mass attributed to a pulmonary artery aneurysm. The pulmonary artery is the second most common site of arterial involvement, with the aorta being the most common, and aneurysms are more common than thromboembolism. Behçet's disease is the most common cause of pulmonary artery aneurysms. Chapter 6. Test paper 3, answers. 160. Hughes-Stoughton syndrome is a rare disorder of unknown etiology that is characterized by the combination of multiple pulmonary artery aneurysms with mural thrombi and deep venous thrombosis. Another well-known finding is the mediastinal widening caused by thrombosis of the SVC and accompanying mediastinal edema. Thrombosis of the brachiocephalic, subclavian, and axillary veins may also accompany SVC occlusion. Arterial involvement may occur in the ascending thoracic aorta and the aortic arch, as well as in the coronary artery and subclavian artery in the thorax. Aneurysm formation occurs more frequently than arterial occlusion. Che E.J., ETAL radiologic and clinical findings of Behçet disease, AVM. 68, a 39-year-old woman weighing 22 stone is referred for weight loss surgery. With regard to bariatric surgical procedures, which one of the following statements concerning complications of the laparoscopic adjustable gastric banding procedure, LAGB, is false? A. Lap band misplacement is usually due to inexperience on the part of the surgeon. B. Stomal stenosis is a rare complication. Chapter 5. Test paper 3, questions. 130. C. Band erosion into the gastric lumen is a rare but late complication of laparoscopic adjustable gastric banding. D. Acute pouch dilation usually results from marked stomal narrowing secondary to overfilling of the band or from distal band slippage and obstruction. E. Distal band slippage is thought to result from recurrent vomiting, overinflation of the band or faulty surgical technique. Technique. 69. A 31-year-old man involved in an RTA has sustained a pelvic fracture and is investigated with Comprehensive Review of Multisystemic Involvement. Radiographics. 2008, 28, 5E31. 68b. Stomal stenosis is a rare complication. The most common complication after gastric banding is stomal stenosis. This complication occurs when the band is too tight, causing excessive luminal narrowing and obstruction. Affected individuals usually present with nausea and vomiting, regurgitation, dysphagia, or upper abdominal pain. When stomal stenosis is found on barium studies in patients with obstructive symptoms, the band should be deflated to increase luminal caliber and relieve the patient's symptoms. Acute pouch dilation usually results from marked stomal narrowing secondary to overfilling of the band or from distal band slippage and obstruction. In this setting, the band should be deflated to prevent further complications, including irreversible pouch dilation and progressive band slippage. Distal band slippage is thought to result from recurrent vomiting, overinflation of the band, or faulty surgical technique. Malpositioning of the band is an unusual complication that occurs at the time of surgical placement, most often when this procedure is performed by an inexperienced surgeon. Band erosion into the gastric lumen is a rare but late complication of laparoscopic adjustable gastric banding and results from high pressures generated by the inflated band, with pressure necrosis of the adjacent gastric wall and subsequent erosion of the band into the lumen. Levine-Miz imaging of bariatric surgery, normal anatomy, and postoperative complications. Radiology. 2014, 270. Retrograde urethropography to assess urethral injury. There is no opacification of the urinary bladder, and contrast is seen to extravasate into the perineum. What is the most likely grade of urethral injury? A. Grade I stretching without tear. B. Incomplete tear grade 2 above the urogenital diaphragm. C. Complete tear grade 2 above the urogenital diaphragm. D. Incomplete tear grade 3 at the level of the urogenital diaphragm. E. Complete tear grade 3 at the level of the urogenital diaphragm. 70. A 66-year-old woman presents (270, 232741). 69. E. Complete tear grade 3 at the level of the urogenital diaphragm. Urethral injuries associated with a pelvic fracture were classified into 5 types by Goldman and Sandler and into 3 types by Colapinto and McCallum, with types 4 and V being exclusive to Goldman and Sandler. Type I. Posterior urethra stretched but intact, no extravasation of contrast. Type 2. Urethra disrupted at the membranoprostatic junction above the urogenital diaphragm. Contrast in pelvis. Type 3. Membranous urethra disrupted, with extension to the proximal bulbous urethra and / or disruption of the urogenital diaphragm. Most common contrast in pelvis and perineum. Type 4. Bladder neck injury with extension into the urethra. And Type V. Partial or complete pure anterior urethral injury. Grades 2 and 3 are subdivided into complete and incomplete tear depending on the absence or presence of bladder filling. Adam A. et.al. Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008. 70. A. Large osteophytes. Presence with progressive worsening of right shoulder pain and limitation of movement. X-ray and MRI show a combination of rotator cuff cuff tear and established arthropathy described as Milwaukee shoulder. All of the following are recognized features, except A. Large osteophytes. B. Multiple loose bodies. C. Subacromial abutment of humeral head. D. Large subchondral cysts. E. Subchondral collapse and deformed humeral head. Osteophytes. Milwaukee shoulder consists of the association of complete tear of the rotator cuff, osteoarthritic changes, non-inflammatory joint effusion containing calcium hydroxyapatite and calcium pyrophosphate dihydrate crystals, hyperplasia of the synovium, destruction of cartilage and subchondral bone, and multiple osteochondral loose bodies. This entity most frequently affects. Chapter 6. Test paper 3, answers. 161. Older women and manifests clinically as a rapidly progressive and destructive arthritis of the shoulder. It manifests as joint space narrowing, subchondral sclerosis with cyst formation, destruction of subchondral bone, soft tissue swelling, capsular calcifications and intraarticular loose bodies. MR imaging demonstrates a large effusion, a complete rotator cuff tear, narrowing of the glenohumeral joint, thinning of cartilage and destruction of subchondral bone. Logger J, et.al. Nonseptic monoarthritis, imaging features with clinical and histopathologic correlation. Head. 71. MRI brain on a patient with head injury shows a 3 times 3 cm hematoma in the right occipital lobe, which returns high signals on both T1W and T2W images. What is the phase of the intracerebral hematoma? A. Hyperacute. B. Acute. C. Early subacute. D. Late subacute. E. Chronic. 72. A3. Radiographics. 2020, S26378. 71. D. Late subacute. Phase age compartment T1W T2W. Hyperacute for 6 hours intracellular oxy-HB, ISO hyperacute 12-48 hours intracellular deoxy-HB hypo extracellular deoxy-HB, ISO early subacute 3-7 days intracellular meth-HB hyper late subacute greater than 7 days extracellular meth-HB hyper chronic greater than 30 days hemosiderin rim hypo. Dannert W. Radiology Review Manual, 7th. 3-month-old infant with abdominal distension is seen to have enlarged adrenal glands on ultrasound along with hepatosplenomegaly. CT confirms the enlarged liver and spleen and demonstrates bilateral enlarged adrenal glands, which are of normal triangular morphology but contain widespread punctate calcification. What is the most likely diagnosis? A. Bilateral neuroblastomas. B. Non-traumatic adrenal hemorrhage. C. Wallman disease. D. Adrenocortical hyperplasia. E. Bilateral adrenocortical carcinoma. 7th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:295. 72. C. Wallman disease. Wallman disease is an uncommon autosomal recessive disorder characterized by accumulation of fat within such tissues as the liver, spleen, lymph nodes and adrenal glands. Accordingly, these tissues will increase in size. The adrenal findings are diagnostic of the condition, with glands that are of normal shape but increased size, with diffuse punctate calcification throughout both glands. It is usually fatal by the age of 6 months. Neuroblastomas may be seen in both adrenal glands simultaneously and are often calcified, although they will usually be large irregular masses. Non-traumatic hemorrhage of both adrenals may be seen, often caused by perinatal stressors, although this also takes the form of a mass and calcification is usually peripheral initially, or dense chronic stage. Adrenal glands may be thickened in adrenocortical hyperplasia, but calcification is not a typical feature. Adrenocortical carcinoma is typically unilateral and is not usually seen until after the age of 6 months. Hindman N. Israel GM, adrenal gland and adrenal mass calcification. J. Radi. 73. A 3-year-old boy presenting with gross hematuria is found to have a renal mass on ultrasound, thought to represent a Wilms tumor. Which of the following statements regarding Wilms tumor is inaccurate? A. Beckwith-Wiedemann syndrome is a recognized association. B. The majority present with an asymptomatic palpable mass. C. Horseshoe kidney is a recognized association. D. Stage 4 disease refers to bilateral renal involvement at diagnosis. E. Nephroblastomatosis is a recognized precursor. Chapter 5. Radiol. 2005, 15:1163-7. 73. D. Stage 4 disease refers to bilateral renal involvement at diagnosis. Wilms tumor has multiple associations. 1/3 of patients with sporadic aniridia develop Wilms tumor. It also occurs in up to 20% of Beckwith-Wiedemann syndrome sufferers, otherwise known as EMG syndrome. Exomphalos, macroglossia, gigantism with hepatomegaly also a feature. Other associations include hemihypertrophy and a variety of genitourinary disorders including Drash syndrome, renal anomalies, including horseshoe kidney, and genital anomalies. Nephroblastomatosis is a recognized precursor and is seen in 99% of cases of bilateral Wilms tumor. Presentation of Wilms tumor is most commonly as an asymptomatic palpable abdominal mass, although other presentations include hypertension, pain and fever. Stage 4 disease refers to the presence of hematogenous or extra-abdominopelvic lymph. 5. Test paper 3, questions. 131. 74. A 60-year-old man has a CXR, which shows a peripheral opacity forming an obtuse angle with the pleura. A CXR prior to attending clinic taken with different inspiration shows a slight change in position and shape of this lesion. A wrist X-ray performed previously following trauma showed periosteal reaction in the radius and ulna. What is the likeliest cause for the above presentation? A. Mesothelioma. B. Primary lung cancer. C. Pleural fibroma. D. Pleural lipoma. E. Asbestosis. Lymph nodes. Dannert W. Radiology Review Manual, 6th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2007:992. 3. 74. C. Pleural fibroma. Chest radiographs of patients with pleural fibroma typically demonstrate a well-defined, lobular, solitary nodule or mass, which may appear to be in the lung periphery and typically abuts a pleural surface or is located within a fissure. Pedunculated tumors may show mobility within the pleural space or changes in shape and orientation on fluoroscopy, or with changes in the patient's position. Chapter 6. Test Paper 3, Answers. 162. Hypertrophic osteoarthropathy is characterized by periosteal reaction without an underlying bone lesion. Causes include bronchogenic carcinoma, squamous cell cancer being the most common, pulmonary lymphoma, lung abscess, bronchiectasis, pulmonary metastases, pleural fibroma, and mesothelioma. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:110. 75, a 56-year-old woman weighing 22 stone, is referred to the bariatric surgeon for a bypass procedure for weight loss. An RU-NY gastric bypass surgery, RYGBP, is performed after discussion about the advantages and disadvantages of the procedure. Regarding complications of this procedure, the following are all true, except A. Extraluminal leak is the most serious early complication of RYGBP. B. Transient anastomotic narrowing and obstruction may occur during the early postoperative period. C. Strictures at the gastrojejunal anastomosis may be caused by post-surgical scarring at the anastomosis or by chronic ischemia resulting from tension on the gastrojejunostomy. D. Anastomotic strictures usually appear on upper GI studies as an irregular long segment narrowing at the gastrojejunal anastomosis. E. Anastomotic leak. 76. 110-524. Rosado de Christensen, M.L. From the archives of the AFIP, localized fibrous tumor of the pleura. Radiographics. 2003, 23, 3759-83. 75. D. Anastomotic strictures usually appear on upper GI studies as irregular long segment narrowing at the gastrojejunal anastomosis. Extraluminal leak is the most serious early complication of RU-NY gastric bypass, occurring in up to 5% of patients. Between 69% and 77% of leaks involve the gastrojejunal anastomosis, but other less common sites of perforation include the gastric pouch, blind-ending jejunal stump and jejunojejunostomy. Leaks usually occur within 10 days of surgery. Early detection is critical because of the risk of abscess formation, peritonitis and sepsis, with a mortality rate of more than 5%. Affected individuals may present with leukocytosis, fever, abdominal pain, and tachycardia. Transient anastomotic narrowing and obstruction may occur during the early post-operative period secondary to residual edema and spasm in this region. Upper GI examinations may reveal focal narrowing of the gastrojejunal anastomosis and thickened, irregular folds in the roux limb. Abutting the anastomosis. These findings usually resolve within several days. Strictures at the gastrojejunal anastomosis have been reported in 3%-9% of patients. These strictures typically develop for weeks or more after surgery. They may be caused by post-surgical scarring at the anastomosis or by chronic ischemia resulting from tension on the gastrojejunostomy. Anastomotic strictures usually appear on upper GI studies as short segments of smooth narrowing at the gastrojejunal anastomosis. Though adhesions are the most common cause of SBO after open RU-NY gastric bypass, internal hernias are the most common cause after the laparoscopic form of surgery. 76. A 36-year-old man notices a hard, non-tender lump in his right testes. He cannot convincingly recollect a history of recent or past trauma to the scrotum. US reveals a well-defined, hyperreflective homogeneous mass without internal calcification or cystic spaces in the right testes. What is the most likely diagnosis? A. Seminoma. B. Teratoma. C. Sertoli cell tumor. D. Lymphoma. E. Embryonal cell tumor. 77. A 76-year-old man with progressive hind and midfoot pain is referred to the radiology department for a plain film of his foot. Advanced neuropathic type arthropathy involving the mid-tarsal joints of the Mark S. Levine. Imaging of bariatric surgery, normal anatomy and postoperative complications. Radiology. 2014, 272. 76. A. Seminoma. Seminoma is the most common pure germ cell tumor. The imaging characteristics of seminomas reflect their uniform cellular nature. On US images, these tumors are generally uniformly hypoechoic. Embryonal carcinoma is the second most common histologic type of testicular tumor after seminoma. The tunica albuginea may be invaded, and the borders of the tumor are less distinct, as expected. They are more heterogeneous and ill-defined than seminomas on US image. Yolk sac tumors account for 80% of childhood testicular tumors, with most cases occurring before the age of 2 years. Imaging findings are nonspecific, especially in children, in whom the only finding may be testicular enlargement without a defined mass. After yolk sac tumor, teratoma is the second most common testicular tumor in children. The complex nature of teratoma is reflected in its sonographic appearance. Teratomas generally form well-circumscribed complex masses. Cysts are a common feature and may be anechoic or complex depending on the cyst contents, i.e. serous, mucoid or keratinous fluid. The foot is noted. All of the following are acquired peripheral causes of neuropathic osteoarthropathy, except A. Diabetes mellitus. B. Leprosy. C. Syringomyelia. D. Repeated intraarticular corticosteroid injections. E. Peripheral nerve injury. 78. Antenatal ultrasound shows of testicular lymphoma is variable and indistinguishable from that of germ cell tumors. Chapter 6. Test Paper 3, Answers. 163. Testicular lymphoma generally appears as discrete hypoechoic lesions, which may completely infiltrate the testicle. Woodward P.J., et.al. From the Archives of the AFIP, Tumors and Tumor-like Lesions of the Testis, Radiologic Pathologic Correlation. Radiographics. 2002, 22, 1189-16. 77. C. Syringomyelia neuropathic osteoarthropathy can be categorized as originating from a congenital or acquired cause. The acquired causes include a central origin, e.g., syringomyelia, spinal cord tumors and multiple sclerosis, or a peripheral origin, e.g., poliomyelitis, leprosy, diabetes mellitus and peripheral nerve injury. Dannert W., Radiology Review Manual, 6th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2007:128. 78. A. Lobar holoprosencephaly shows an abnormal facial contour with a large cyst without any cortical mantle of cerebral tissue anteriorly. Septum pellucidum, falx cerebri and optic tracts are not identified with evidence of a fused midline thalamus. A single large ventricle is identified. Normal brain stem, midbrain and cerebellum are noted. What is the diagnosis? A. Lobar holoprosencephaly. B. Lobar holoprosencephaly. C. Hydranencephaly. D. Anencephaly. E. Congenital hydrocephalus. Chapter 5. Holoprosencephaly, HOPE, is considered the most common malformation of the brain and face in humans. In a lobar HOPE, prosencephalic cleavage fails, resulting in a single midline forebrain with a primitive monoventricle often associated with a large dorsal cyst. The olfactory bulbs and tracts, the corpus callosum and anterior commissure, the cavum septum pellucidum, and the interhemispheric fissure are absent, whereas the optic nerves may be normal, fused or absent. The basal ganglia, hypothalamic and thalamic nuclei are typically fused in the midline, resulting in absence of the third ventricle. In lobar HOPE, the interhemispheric fissure is present along nearly the entire midline, and the thalami are completely or almost completely separated. The corpus callosum may be normal or incomplete, but the cavum septum pellucidum is always absent. Hydranencephaly is the result of a vascular insult, anterior circulation, with the cerebral hemispheres variably replaced by fluid covered with leptomeninges and dura. Falx cerebri is present. The cerebellum, midbrain, thalami, basal ganglia, choroid plexus and portions of the occipital lobes, all fed by the posterior circulation, are typically preserved. It is differentiated from hydrocephalus by absence of an intact rim of cortex, seen with even the most severe hydrocephalus. Kurtzub, Johnson P.T., Diagnosis please. Case 7, Hydranencephaly. Radiology. 1999, 210, 2/4/1922. Winter T.C., et al. Holoprosencephaly, a survey of the entity, with embryology and fetal imaging. Radiographics. 2015, 35, 1-275-90. 79. Chronic pulmonary. 79. Causes of tree in bud appearance include all, except A, tuberculosis. B, allergic bronchopulmonary aspergillosis. C, cystic fibrosis. D, tumor emboli. E, chronic pulmonary embolism. 80. Following a motorcycle accident, a patient noticed pulmonary embolism. The tree in bud pattern on HRCT is characterized by small centrilobular nodules of soft tissue attenuation connected to multiple branching linear structures of similar caliber originating from a single stalk. Initially described in cases of endobronchial mycobacterium tuberculosis, it has subsequently been reported in peripheral airways diseases such as infection, bacterial, fungal, viral or parasitic, congenital disorders, like cystic fibrosis and Cardiganer's syndrome, idiopathic disorders, obliterative bronchiolitis, panbronchiolitis, aspiration, inhalation, immunologic disorders, like ABPA, connective tissue disorders and peripheral pulmonary vascular diseases such as neoplastic pulmonary emboli. Rossi S.E., tree in bud pattern at thin section CT of the lungs, radiologic pathologic overview. Radiographics. 2005, 25, 3789-801. 80. A. Pseudomeningus notices wasting of the small muscles of his left hand. Neurologist diagnoses brachial plexus injury and arranges a MRI to determine whether it is preganglionic or postganglionic. Which of the following findings would suggest a preganglionic brachial plexus injury? A. Pseudomeningocele. B. Thickened nerve. C. Increased T2 signal in the peripheral nerve. D. Discontinuity of the peripheral nerve with distal nerve contraction. E. Direct compression of the brachial plexus by hematoma. 81. A3. Pseudomeningocele. The prognosis is better in postganglionic injuries, where surgical repair in the form of nerve grafting is possible. In preganglionic injuries, usually nerve root avulsions, direct surgical repair cannot be performed. A MRI scan of postganglionic injuries can show thickened nerves with a low signal intensity on T1, weighted images, and an increased signal intensity on T2, weighted images. Nerve may be in contiguity, or there can be discontinuity with distal nerve contraction. Direct brachial plexus compression by a hematoma, fracture fragment, or callus formation can also cause. Chapter 6. Test Paper 3, Answers. 164. Brachial plexopathy. A MRI scan of preganglionic injuries can show nerve root avulsions with or without pseudomeningoceles. Pseudomeningocele are cerebrospinal fluid collections resulting from a dural tear. The presence of a pseudomeningocele is a valuable sign. Spinal cord abnormalities occur in 20% of those with preganglionic injuries, such as edema, hemorrhage and myelomalacia. An uncommon but useful finding is the enhancement of intradural nerve roots or root. Shurka J., Cherian R.A., Alexander M., Thomas B.P., MRI of brachial plexopathies. Clinical Radiology 2009, 64, 20818. Van ESHW, Ballin TL, Van Heeswijk HP, MRI of the brachial plexus, a pictorial review. European Journal of Radiology 74:391-402. 81, C. Hamartoma of tubercinarium. Hypothalamic hamartomas are developmental malformations consisting of tumor-like masses located in the tubercinarium of the hypothalamus. Most